All right, good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for this afternoon, Dr. Wes Johnson, who will be presenting on the treatment of animal bites and exposure. At this time, I'm going to stop sharing my screen and turn the presentation over to Dr. Johnson.
All right, I appreciate it. Let me know. You'll see my screen.
We can see it. It looks like you might be in presenter mode, though. Oh, there we go. Looks perfect.
Okay, sounds good. So today will be an extension of Dr. Johnson's topics last week, talking a little bit about kind of the things we can get from different pets and animals. And this week, I'll focus a little bit more on the treatment. So with our objectives today, we'll quickly review some of the epidemiology of animal bites, just so that we can get a baseline understanding of some of the numbers that we see with these different exposures. Additionally, we hope to identify the treatment of animal bites and exposures. And then finally, I want to take a little bit more of a public health outlook and talk a little bit about some of the vaccine recommendations that we see with these different animal bites and exposures. And so with that, we can jump into epidemiology. And when it comes to numbers, there are about 5 million animal bites. This is specific to bites that are occurring on an annual basis here in the United States. And this actually accounts for about 1% of emergency department visits. So not necessarily a frequent occurrence, but we are seeing this from time to time. And as far as the cost go, this is about 50 million annually. So certainly something that we need to be aware of and know how to treat and deal with when these patients show up. You can see on the right there with that graph that as far as animal bites, the distribution that we see for patients that are presenting to the emergency department, dogs are far and away the most common bites that are showing up and needing treatment, with second being cats at about 5 to 10%. And then, sorry, the percentage for dogs, we're looking at about 85%. And then the red bar there is other. So this is things like snakes, rodents, bats, just various other animals. And so with dog and cat bites being the biggest contributors to animal bites that require a visit to the emergency department, let's go ahead and start there with talking a little bit about dog and cat bites. Now, when it comes to dog bites, like I already mentioned, this is far and away our most common that's needing treatment within the emergency department, with about 4 to 5 million on an annual basis. As far as patient populations that might be more at risk or that we see this happen to more, typically we think of younger males, and this does seem to make sense. A young boy is rambunctious and maybe playing a little rough with the dog, ends up getting bitten. As far as bacteria, you probably remember this if you were here last week from Dr. Johnson's presentation, but Pasteurella really is the big one that we see, and specifically Pasteurella multicida is the most commonly cultured one from these different animal bites. However, we can see a few other organisms like strep, staph, Neisseria, Corynebacterium, Catnus cytophaga. So a various array of different organisms that can show up, but again, Pasteurella is our biggest one. The other thing to point out here too is the infection risk that comes with dog bites. It's not really that high, about 3 to 18%. Most places, if you look this up, it'll be around 10 to 15. So again, we're not commonly seeing these become infected. And when we think about how dog bites typically present, it's typically more of a tearing injury or potentially a crush injury, especially when we think about kind of these smaller bones within our hands. And this makes sense when we look at this picture here on the right of dogs' teeth. They're not necessarily razor sharp, and it can cause more, again, of this tearing injury. And so you can see this here in this picture. It is, again, a very open wound and not these small little puncture marks from the teeth. Now, obviously, patients present with a wound like this, but if we do have a more established infection, or maybe the patient waits a while to come into the emergency department, they might end up presenting with fever, maybe altered mental status, or even all the way up to organ failure, kind of depending what organism is causing the infection. And so again, this is something that we want to make sure to treat, but as far as patients presenting, oftentimes it's these open wounds that look like this more acutely. So moving on to cat bites, these do vary a little bit from dog bites, but there is some overlap. As far as numbers go, we're seeing about 500,000 occur annually for patients that are coming into the ED. As far as patient populations we may see this more commonly with, female individuals as well as older individuals having those exposures to cats. As far as pathogens, there is some overlap with Pasteurella once again being our big contributor, but we also have various other organisms when it comes to cats, Staph, Yersinia, Francisella, Sporothrix. So this one, we don't typically see this with cats here in the United States. This is more within South America that we can see this being transmitted from cats to humans. But the other one that I do want to make sure to call out is Bartonella hen flea. So this is cat scratch fever, essentially, is what you might have heard this referred to as. And additionally, we do have cat mouse cytophaga as well. Now, you will notice here with infection risk, it's quite a bit more than dog bite infection risk. And this tends to make sense when you think about it from a pathophysiological standpoint or kind of how that bite is actually happening. So you see the teeth here on this picture, they're very sharp. And essentially what happens is they make these small puncture wounds, and more so these teeth will act to inoculate bacteria within the deeper tissue and muscle. So like you see here, that's not a terrible wound on this patient's hand. But again, it's probably deeper because of those sharp teeth, and there's a whole host of different bacteria being inoculated within that area. And so really when it comes to presentation, typically patients aren't necessarily presenting with these really open gaping wounds when it comes to cat bites or scratches. And the other things that can happen, so if a patient does obviously wait around or maybe has more systemic infections, at that point, patients might have fever, altered mental status, or lymphadenopathy. I do want to call this one out because this is what we can get, the lymphadenopathy from Bartonella. So you see here, the gentleman in this picture does have a rather enlarged lymph node there under his in his armpit. And so most of the time, though, these are self-limiting and not necessarily that big of a deal. But one we can see from time to time. So now that we've briefly discussed how these patients typically present, let's talk about how we manage these patients from a medical perspective with antibiotics. And so really our first line therapy, the tried and true way in which we typically treat these patients that present with a dog or cat bite is amoxicillin clavulanate. So we're giving this twice a day for 3 to 5 days. If the patient, for whatever reason, maybe cannot take oral medications, then at that point, we can go with ampicillin sulbactam. Again, very similar spectrum of coverage. And these are great options because they don't come with too many side effects. They're not overly broad, and they really cover the bacteria that we are thinking about with dog and cat bites. I do have listed here, though, our second line therapies. And so we really try to utilize these whenever patients have a more severe reaction to the penicillin class of medications, and therefore can't take amoxicillin. So we have several options, thankfully, though. So things like sulfamethoxazole, trimethoprim plus metronidazole, or potentially doxycycline and metronidazole. Or if a patient maybe has bad adherence, we can consolidate this to moxifloxacin as a single agent to give us that coverage of our typical pathogens. And you'll notice too here, it's important that we have anaerobic coverage. While it's not overly common that we are able to isolate these pathogens or that they're the true cause of any infections related with these bites, they can show up every now and then. As far as intravenous, we also have a few options there as well that are not penicillin based with cefoxitin or potentially levofloxacin and clindamycin. So you may be asking yourself, does every bite need antibiotic prophylaxis? Because if you're kind of like me, you probably had a dog bite or a cat bite that was pretty insignificant and you ended up being fine without antibiotics. There was no signs of infection. But we do have guideline recommendations to help us decipher when it might be appropriate to utilize antibiotic prophylaxis. So the Infectious Diseases Society of America made a skin and soft tissue infection guideline, and they did give recommendations for dog and cat bites. And so these patients that fit kind of in these categories there on the left, so immunocompromised, asplenic, we certainly need to consider covering them with antibiotics after a bite exposure. But there's a few others that we do have to consider. A patient presents with edema, additionally, a moderate or severe injury, which is very much up to the interpretation of the provider that deals with the patient. So that can encompass quite a large amount of patients, and they end up needing antibiotics. And then the other one that we certainly do want to ensure we have antibiotic coverage with is those bites or injuries to the face or hands. And so you kind of have to ask yourself, this is probably going to encompass a large amount of patients. And are we really seeing a benefit by giving antibiotics to all of these patients? And so for the most part, there's not a ton of literature to really assess if we have this huge benefit from prophylactic antibiotics in these situations. But there was a meta-analysis back in 2001, and really the biggest benefit that it did show for giving prophylactic antibiotics after a bite was patients that had particularly hand bites. So patients present with a bite on the hand, which is very typical if you think about it. That's kind of how we're interacting or petting our different pets. So that kind of checks out. But for the patients that did receive antibiotics, 2% of that group ended up with an infection, while patients that did not receive an antibiotic, nearly 30% ended up with an infection. So certainly worth, if a patient comes in with a hand bite, probably should give them antibiotic prophylaxis just to ensure that does not become infected. And so this covers some of our typical prophylaxis approaches to these patients, but I wanted to call out a few disease states that are a bit more rare and certainly worth discussing some of the recommendations for how to treat. And so this would be more established infections. The two here can be or cause pretty serious disease states, and patients can present very critically. But specifically capnocytophaga canemorsus, as well as Bartonella. And with capnocytophaga, we don't necessarily expect to see this in all of our patients. Probably patients will have some sort of immunocompromising condition, but patients can present with a bacteremia, endocarditis, even meningitis that's caused by this particular pathogen. As far as our treatments for these patients, amoxicillin clavulanate works perfectly fine. But if a patient isn't able to take that, we do have several options. But you can see these are rather broad, so piperacillin, tazobactam, and meropenem. With Bartonella, so this is the cat scratch disease, but this is a pretty interesting one. So I mentioned already you can have lymphadenopathy, lymphadenitis, but patients can also present with bacteremia and endocarditis as well. And this is of particular concern when we think about a particular disease state with culture negative endocarditis. Bartonella can sometimes be at play here, and we might not be able to culture it whenever we're working these patients up. But as far as treatment goes, I've already mentioned this a little bit, but when it comes to lymphadenopathy, we can just go ahead and watch and wait. We don't necessarily have to provide treatment for these patients. However, if we do have more of this invasive infection, doxycycline is typically our preferred therapy. We can also utilize azithromycin, but especially in endocarditis, we do prefer to use double coverage. And so utilizing doxycycline, typically gentamicin is the second agent added there, but we can utilize rifampin. So again, we have plenty of options, which is very nice, but these are some of our more severe presentations or organisms that can cause severe presentations. So we've discussed some of the aspects of more common bites and exposures, but what about some of the less common bites and exposures to different animals? So here I'll talk a little bit about potential exposures with rodents, maybe aquatic animals or aquatic environments, as well as various worms that we might pick up from our different animals. Now, first up, thinking about rodent bites, you can see here the incidence. This isn't happening commonly. However, 200 annually is probably underestimating. Most patients probably are perfectly fine if they get bit by a mouse. So again, this isn't overly common. But as far as risk factors of patients, we might see this more commonly with children, but also poverty, and especially when we think about homelessness. So patients that are living kind of in and amongst different rodents, they will certainly be at more of a risk of having that exposure or bites. And the bacteria that we do have to worry about for rodents here in the United States is Streptobacillus moniliformis. So this is specific to here in the US. We can also see this in Europe. But as far as symptoms, how patients might present after they're bitten by a rodent, we can have really a whole host of different presentations with fever, rash, all the way up to different myalgias. And the next up would be the aquatic exposures and bites. So less common. Here in Kentucky, we can see these. Obviously, we have a lot of lakes and different bodies of water for patients to be fishing and having exposure to catfish and different types of fish. But as far as incidence goes, it's really rather unknown. But the bacteria we do have to worry about here, it depends really on what type of body of water. And what I mean by that with Vibrio, this is more specific to salt water. So whether it's some sort of fish or other animal within salt water, that can cause exposure, or just having an open wound within salt water. This is where we find Vibrio. Aeromonas is more specific to freshwater, so thinking lakes, ponds, but additionally a little less commonly, but we can see this with patients that might be into the fish keeping hobby. So they have a fish tank at home, they could potentially have exposure to this bacteria. This also includes Mycobacterium marinum. This is another odd organism that we can see, and we do see this in patients that might have an aquarium and be into the fish keeping hobby. As far as symptoms, typically we're just seeing wound infections, but it can become more systemic with pneumonia and GI symptoms as well. I also kind of added on here a little bit of an interesting tidbit, but you kind of never know what you're going to see when it comes to aquatic exposures. I found a case report. It was about a 22-month-old boy who suffered a piranha bite, and it actually ended up amputating part of his finger. So you never know when you might need to know the bacteria of various fish. But again, just odd exposures that can happen, kind of depending where a patient lives or what exposures they have to different animals. Next up, though, will be worms. And so specifically here, I'm talking about hookworms and tapeworms. We can unfortunately pick these up from our various animals that we might own, and patients that are probably more likely to have these different types of hookworms and tapeworms. Oftentimes children, because they're out in the yard playing and they're kind of in and rolling around in the environment where these worms are. Additionally, we can see this with poor sanitation in an area. So first up, as far as these parasites that we'll see, so Ancylostoma, I have a difficult time with that one, but this is our hookworm, or one of our hookworms that we can see. And the life cycle there is there on the right. So our pets will have a bowel movement, and within the feces, there will be these larvae. They eventually mature, and if you have the unfortunate luck of having contact with these larvae in your skin, that's where they can get inside your skin and have these different manifestations. And then the second one is more of is the tapeworm, and so Dipylidium. This is one we can also get from our pets. If you have, again, our pets might have these tapeworms because they have ingestion of these fleas that are carrying the parasites, but if you somehow manage to ingest one of these fleas, this is potentially how we can have these tapeworms occur in humans. As far as symptoms go, oftentimes this is limited to rash and particularly GI issues, as you would expect with the tapeworm. As far as treatments for these different groups, I do want to make sure to highlight all of these. When it comes to rodents, rat bite fever is the particular disease state that we can see with that streptobacillus. And really, and thankfully, our therapy of choice is penicillin. So very easy for most patients to take, very narrow spectrum, but we typically give patients IV to start them off, and then we can send them home with oral therapy for about 10 to 14 days. If a patient does, however, present, they don't have rat bite fever, maybe they just got bit by a rat though, and we just want to make sure that we give them prophylaxis. We can give them oral penicillin for about 3 days, and they should be perfectly fine. As far as aquatic exposures, you can see here, as far as freshwater goes, we do have a few options to cover our Aeromonas species with levofloxacin and ceftriaxone. And then with saltwater exposures, we do have a few options as well with levofloxacin and doxycycline. As far as Mycobacterium marinum, again, this isn't very common, but if this is coming up, we can treat this with clarithromycin or minocycline. And I will say with Mycobacterium marinum, that is one that we're often treating these patients for quite some time, for several months or kind of until resolution of those potential nodules that you can get on your hands. And then for worms, for our hookworms, we do have a few options with albendazole or ivermectin. Ivermectin is that one-time dose, so that might be a little bit more convenient for patients. And then with tapeworms, we can utilize praziquantel and essentially give that one-time dose and be done with that. So I've kind of talked about treatments and how these patients might present, but I also wanted to shift now to thinking about maybe more of a public health aspect and hitting on vaccines that we might be utilizing after an animal exposure or bites. And really the two big ones that we have to think about after animal bites and exposures is rabies and then tetanus. And when it comes to rabies, really most of the incidence of rabies is found within wildlife. And what I mean by that is not necessarily our household pets, but you can see that nearly 90% are made up within wildlife, thinking raccoons, skunks, foxes. Here in America, raccoons are the most frequently reported animal to have rabies, but specific to Kentucky, skunks are the primary reservoir. So not only should the smell keep you away from skunks, but probably should stay away with risk of rabies. And just kind of to give you overall numbers, rabies is exceptionally rare. There's only been 52 cases reported since 2000. So this is not something we're seeing very often. The other one I want to touch on is tetanus. And really, when we think about tetanus, this is occurring most of the time within individuals that may be without the recommended vaccines or they're not up to date. And as far as tetanus after animal bites, there's not a whole lot out there. This recommendation does exist, but if you try and look some case reports up, there's not a whole lot. I did come across one case report where it confirms tetanus happened after a dog bite, but like I said, not a whole lot out there. And as far as numbers for tetanus, this is another disease state which we really don't see very high numbers of. In 2017, there was only 33 cases. And so now I want to transition and discuss rabies and when we may need to be concerned about certain animal exposures, putting us at risk for rabies. And so the CDC is actually a really good resource if you ever have any questions about a certain animal exposure or just want to look into this yourself. But they do give recommendations if you have, in particular, an animal bite from that first group of dogs, cats, or ferrets. If that animal is thought to be rabid or known to be rabid, then we go ahead and initiate post-exposure prophylaxis to try and mitigate the risk of getting rabies. If the animal is unknown, so a lot of the times how this might happen is a neighbor's dog might bite somebody. This is where we can see this. What ends up having to happen is that animal has to get quarantined for 10 days. And then if they're showing no signs of being rabid, at that point they can be let out, and then the patient doesn't necessarily have to do anything from a post-exposure prophylaxis standpoint. The CDC notes that after the 10-day quarantine, if an animal's fine, there's never been any cases reported of a patient getting rabies after that. For these kind of in-between animals, so livestock, horses, rodents, rabbits, this is really going to be more of a case-by-case basis. So if you have the unfortunate luck of getting bitten by one of these animals, then probably best to consult your health officials. And then finally, this red group, the raccoons, skunks, foxes, and bats. If there's any exposure at all, these are ones that we really don't wait around. We give that immediate post-exposure prophylaxis because, as we know, these are animals that are probably our most common reservoirs for rabies. And whenever I've kind of talked about post-exposure prophylaxis, I want to make sure to go over what that actually means and what that looks like, because this is very important that we're providing this appropriate regimen for patients that present with a potential rabies exposure. The first component of this is human rabies immune globulin, and this is given as an intramuscular injection, and it's given in and around the wound. And the thought there is that we're giving these active antibodies at the site of the potential rabies exposure. And then the dose listed here is 20 units per kilogram based on the patient's weight. So that's the first component. But the second component of post-exposure prophylaxis is the addition of the vaccine. And this is given on day 0, 3, 7, and 14. And if an individual is immunocompromised, then we'll give them that additional dose on day 28. And so it's very important for patients to get both components of these. Essentially, if you read on the CDC a little bit, there's really not been any cases if a patient appropriately gets the right immune globulin dose and administration along with the appropriate vaccines, there's not necessarily any risk. It's next to zero, basically, for getting an actual rabies infection. And that's the goal, because really, if a patient is to have a true rabies infection, there's not much we can do. Most of the time, these patients do end up dying, and there's really only a few case reports of patients that end up making it through this disease state. So the best bet is prevention. So this is why it's so important when we think about a patient that might present with a potential exposure. So then the second vaccine that's worth considering for patients presenting with animal bites is the tetanus vaccine. So this is talked about a little bit both on the CDC website, but you can also find a recommendation with that skin and soft tissue infection guidelines as it relates to animal bites. But they recommend typically giving the tetanus toxoid booster if a patient has not had a vaccine booster within the previous 5 years. So again, this is important to ask the patient what their history is with their tetanus vaccine and then administer accordingly. Tdap is the preferred formulation for these patients. However, we can give TD or DTaP as well. And the last thing I did want to touch on is it is public health related, not necessarily vaccines, but it's reporting. And so I've actually seen this in patients that have presented here to the hospital with an animal bite, but there are animal bite reporting forms. Essentially, if you are bitten by one of these animals and then need to present to the hospital, it's important that we fill out these forms just to ensure that we're tracking these bites appropriately, ensuring that all the appropriate steps are taken to mitigate any risk of infection, rabies, tetanus, that type of thing. And this particular form is from here in Louisville. But based on your area, you probably will have a form that's specific to your county or local health department. So again, if you find yourself in that situation of being bitten by an animal, probably best to go ahead and fill out this form. And with that, I'll take any questions and finish up.
All right, I just want to say thank you to Dr. Johnson for this wonderful presentation. And if you guys have any questions specifically that come up after this, don't hesitate to reach out. We can get you guys in contact. I invite everybody back next week for Grand Rounds. Thank you.